Thank you so much to Professor Fakri and all the Egyptian Venous Forum friends and colleagues for this opportunity to brainstorm together on how strategy can win against the technique. What do I mean? If we look at this picture, we don't know who is really going to win in front of the comparison of the small kid who might have a better strategy to attack the big reflex, let's say so, represented by the adult sumo player. Of course, I'm very sorry not to be with you in person for this important event. I look forward for gathering together in other occasions in which we will still keep talking about the importance of physics in our everyday practice in the operating room. Of course, we don't want to dive into the nitty-gritty details of all the laws of physics that we should know, but we should just remember one, I'd say. And that one is the Poiseuille law, that is stating that if we want to create a flow from a point A to a point B, all we need is a pressure gradient. And of course, it's a pressure gradient that we need to create a reflex from a point B to a point A eventually. Now, looking at the point A and point B of the most typical scenario in hemodynamics could be the great saphenous vein, saphenofemoral junction, and the re-entry point. So the pressure gradient that is created there is what is really driving the reflex, for which is not so interesting to know if there is the reflex. Most of the time it is obvious, but it is far more important to understand where the reflex starts and where it ends. And in this typical example, then the point will be the one of the saphenofemoral junction with a re-entry along the saphenous trunk or along an incompetent tributary that is draining into a re-entry perforating vein. This is something we've been investigating for quite a long time to understand in particular how the force of physics are involved in the drainage that is leading from the surface toward the deepest compartment and vice versa. So if you're interested, we publish quite a lot of literature with our departments of physics, just PubMed for venous hemodynamics with our research group, and you will find quite a lot of reasons that are the base, the fundamentals for which the amletic question for us is not so amletic, to ablate or not to ablate. Well, we usually prefer absolutely not to ablate, and this is quite a point of the discussion, particularly for those scenarios in which an ablation is needed, like, for example, in the US, to get a reimbursement. But of course, we can ablate a shorter segment and still get a reimbursement while applying the best hemodynamic principle for our patients, who most of the time are not really having a saphenous trunk that is diseased, as we can see in the operating room, rather the incompetent tributary that is the real battlefield, I would say, for venous hypertension. So, of course, we can keep on proposing new techniques to our patients, looking like very cool, but in reality, offering the same ablative strategy. Burn it, glue it, torture it. Still, it's always ablation like an own stripping that was first described by Bucachis of Cordoba, that is actually giving an explanation as a phenomenon to the fact that the recurrence rate remains basically the same along the last 1 or 2 decades. Metaphorically, we could say is like giving brand new weapons to the army while instructing the army to go always in the same direction for which the results of the battle is not changing. And in reality, we have the direction of the guidelines that has been talking to us about the importance of Saphenous Sparing and hemodynamic approaches since back in the days, since 2011 and even before. But of course, highlighting that, of course, if you want to do it, you must know how to do it properly, because this is really a little bit of haute couture compared to pret-à-porter. What I mean by this is that far easier, of course, to just ablate all the system rather than identifying the leaking point and understanding if the re-entry points can be useful or not for proper venous drainage. So it can work, actually works, but how and how complicated it is. Well, it's not so complicated if you really think about the Poiseuille law I was mentioning before. You have 1 or 2 escape points with a re-entry perforating vein that is draining back into the deep system. So when we are talking about the Shiva, we are talking about pressure gradients that are stopped by ligations or segmental ablations by thermal tumescent or non-thermal non-tumescent, eventually also by sclerotherapy in a limited track. Different is the concept of Asbal that is based on the ascending theory, for which again we spare the saphenous trunk if we arrive on time, and then we remove what they call the reservoir. But if you arrive too late in that principle, you can remove the saphenous trunk. So it's a little bit of a different interpretation. Independently by Shiva or Asval, it's important to interpret the hemodynamics so that we understand, for example, when we have a higher risk of recurrence. So, for example, when we have an incompetent iliofemoral tract, we published that we have up to 5 times almost the risk of developing a recurrence. So it's very important in our hemodynamic assessment to understand who we have in front of us in terms of hemodynamics. In these cases of reflux, we still perform a mini invasive high tie with a titanium clip flash on the femoral. It's a small incision on the inguinal crease, so not really visible, and it gives a very good results at 5 years follow-up. One important consideration we should do when we're looking at the perforating veins is not just the outward diastolic flow, rather the net flow, for which another important publication of our group is based on the QDP analysis. QDP is the acronym for Quality Doppler Profiles. It's a multi-gate analysis, so we're talking about 9 millimeters depth observation with 256 sample volumes acting at the same time, telling us that in a large percentage of cases, when we have an outward diastolic flow, in reality, the net flow is inward because there is a balance of the pressures in between the superficial and the deep system. So having a 0.5 outward diastolic flow is not enough to consider the reentry perforating vein as incompetent rather than a reentry one. Another publication we did on the saphenous sparing approach focused also on the small saphenous vein with a hybrid technique for which we were performing a disconnection of the saphenopopliteal junction and then injecting foam and twisting the proximal stump, so to make sure that we were going flush on the popliteal vein while closing also the eventual tributaries coming there, keeping the incision extremely small because we know that in quite a high percentage of cases we can find a saphenopopliteal junction that is far higher, multitruncular, therefore limiting the results in terms of recurrence and actually increasing the risk of having a paresthesia. And we demonstrated by this publication that by this approach we can contain the nerve damage risk. Then we demonstrated with another publication that it is possible to perform saphenous sparing also by endovenous thermal tumescent, comparing laser and radiofrequency, so 6 centimeter segmental shrinkage, showcasing that there was no significant difference between the radiofrequency and lasers that were offering a competitive results compared to the more traditional ablative procedure. For which, if I have to sum up my workflow in terms of hemodynamic interpretation, as you can see, if there is an incompetence of the iliofemoral tract, I go for a mini-invasive high tie by titanium clip. If the terminal valve is incompetent at both Valsalva and compression relaxation, then I go for a segmental thermal tumescent versus non-thermal non-tumescent eventually of the saphenofemoral arch. The leaking points at the tributary levels, of course, they can go by sclerotherapy or by ligation based on the setting, that could be sterile or not, on the fact that I have eventually an escape point that is not easily accessible, for example, a pelvic one. And in terms of dilation, we perform sclerotherapy also in large calibers, of course, diluting the sessions in multiple stages. I like to conclude quoting Glauco Bassi, who was one of the founders of the UIP, now WIP. He was saying that at that time, surgery, compression, and sclerotherapy were the pillars of modern phlebology. And now, of course, we have to add innovative devices. Mini-invasive surgery still remains, as I was mentioning, regarding specific cases, but we have to keep at the center strategy because it's not just a matter of technique that we are using, rather indeed of the strategy that hopefully is hemodynamic, so that we can demonstrate that the strategy actually wins against the technique, so that we can finally actually improve the outcomes that remains always more or less at the same level. This is not really a new dawn in phlebology. This has been presented many times along the years, so hopefully it will keep on growing. and this is not a dawn, was actually a metaphor for this image. That is not a rising sun, rather the tip of my laser fiber coming out from a GSV that was treated but still spared. You can find all these topics in the large documents we published after the VWIN events in 2019 about guidelines, 2022 about evidence-based medicine with many different representatives from all around the world. And of course, it was a joy having with us also Egyptian representatives in the most institutional meeting in Rome. There was a global historic moment in which we delivered the valid document that is now published also in International Geology Journal, for which I hope you will like to have a look at that, and hopefully also translate it in Arabic so that we can speak with the different governments talking about appropriateness and affordability in venous and lymphatic care. To do this, of course, it is fundamental to include a real-world data scenario for which the V-Registry project keeps on going, already in Arabic, thanks to the collaboration of the Egyptian Venous Forum, for which we look forward for presenting the data that we are now presenting in a very important journal in Africa for the first time with a global event that is looking forward for working shoulder by shoulder with the Egyptian Venous Forum and Professor Fakhri team, putting Africa at the center, as in this very beautiful institutional meeting room in Nairobi this December 17, 19 for the V-Africa Act Leg Gathering World Congress, for which I look forward to collaborate more and more with you, remaining at your disposal for whatever need. Just feel free to reach out and just send me eventually a text or whatever comment. Looking forward for V-Africa acting again together. Ciao.